thank you for all the different doctors for inviting me again to this nice congress and meeting. And also, it's my pleasure to present our next speaker, Dr. Sahar Lashin. She's Associate Professor in Veterinary Medicine at the UCLA and the lead physician at South Wilderness, also at the UCLA. She will lecture us about doctoring and continuity of care. So,
thank you very much. So just to add, I'm an assistant professor in Cairo University, and that's the beginning and the end too. Thank you very much, Dr. Siraj. I'm honored to be here today. Thank you for mentoring me forever, for giving me this great chance to be able to come and present in this great conference. And I would like to move around and ask you questions. It's not possible because of the clicker, but I will still get around it. So I start usually with asking a few questions, and it's a survey I do for my own interest. So having all the doctors around here and having all the GI doctors, how many of the GI doctors have the first screening colonoscopy for cancer colon done for themselves? Oh my God, just one. Congratulations, you guys are that. So, do we believe in the guidelines or do we have our own guidelines? We do that to patients. We ask them to do that. We tell them you should do that. But we don't do that on ourselves. So this is one of the guidelines which is difficult to achieve, or we don't just believe in. Any explanation?
Maybe the doctors that you asked are younger than 50 years, so it's not the case.
I can see that, yeah. All right, so back to the doctoring, which is the lecture for today. My great professor, Dr. Wahidus, I had a very nice encounter yesterday, seeing him, and he was asking me about the lecture I'm going to give today, and I told him it's doctoring. He said, what do you mean? And I told him this is exactly what happened to me when I first heard about doctoring. So doctoring is a process, it's a thought process, rather than just a name. And by the way, in Egypt, as Egyptian doctors, we have been doing this forever. We just didn't know that we're doing it. We didn't know that this is a title for what we are doing and practicing. It's actually a global medical trend, and there is a lot of shifting of minds of the doctors around the world for that. Giving you an explanation of why I'm interested in this, it was one of the unique things that happened in my life that I had about 18 years experience in Cairo University as a resident, as a faculty member, as a teacher, teaching medical students, taking care of the patients over there, and then some paradigm shift in life, and I crossed the ocean over to the other side of the world. And I had the chance to be able, with the mature experience that I have here, to see the difference with what I had to do starting from scratch again. So after 20 years of the first residency in Qasr al-Aini, I had my second residency over there. That's to keep you young in heart. You can always have residency anytime in life, but believe me, you have to know what you are getting into. So, getting the experience in Egypt with all the limitations of resources and the ways that we learn how to get over it, how to achieve the best results, how to get the medical senses on the tips of our fingers, how we can really take care of patients when we don't have much, when we don't have data, when we don't have fine medical records. We are doing a great job in Egypt. We might underestimate ourselves, but that's true. The achievements, the results, the medical care that we do with the minimum of what we have made us a very special type of doctors. We can really deal with a lot of challenges. Going to the US and repeating the residency over there, which is the only way to be a doctor in the US, and practice and touch patients and work with them. My residency was in a place called Sinai Grace Hospital in Detroit, Michigan. And for those who don't know, this is one of the highest crime areas in the US. So it's all the action. You sit in the hospital, in the ER, you hear gunshots on the corner around in the street, and then you get the patient and take care of it. You take care of the bullets. You have to ask the patient if they have bullets in their body. Usually, that's in the past medical history. Most of my patients had at least 1 or 2 bullets still in there. They cannot have like certain imaging because they're gonna get stuck to the machine. It's a lot of difference in medical fields. With finishing the residency, I started to work as a hospitalist, which we don't have it here, and it was like an everlasting residency. You are a resident with no team, with no professors, with nobody except yourself. You have the patients, they are their own, theirs. These patients are yours, and you are theirs. And you're carrying a pager, just like the stories you see on the TV. You're having a Cisco phone, you're responsible about the ICU in most of the time, with the ventilators, with the vasopressors, and just take care. You take the decisions with the families, you have to counsel, you have to talk to them, and you have to learn a lot of things which I really didn't think I need before. Something called where you're going to discharge the patient to, which is what you mean. We usually discharge patients in Egypt to their home. They have families, they have homes, that's where they should be, and that's where they usually die. Well, it's not the same. Over there is a lot of other things which we didn't know before. Something called SNF, you're going to find even here. Something called palliative care, which I didn't know before. Something called hospice, which I think is a good thing that we can utilize here sometimes in certain situations. Having the teaching interest, I did something called Cambridge Diploma for Teachers and Trainers to be able to teach to my students here in Cairo before even moving to the US. And from there, I discovered that there is many things that we have as educators to implement for our students to be able to get them into the right track to be doctors and to be teachers later on. With the limited resources that we are talking about and the difficulties that we have to overcome, and it's just not the difficulties for you as a doctor, it's actually a problem with the population of the patients that we're dealing with. We have a great challenges encountered in our medical practice because of the patient's perception and conceptions. So the patient comes to you, they have a preset mind that you need certain things to be done. The patient will present with nothing in hand. You don't have the history, you don't know what happened before. He might give you some things about the medication he took. Maybe he did a surgery, you don't remember where. You can't get or retrieve the information. You're totally blind. You are thrown in the ocean. And still, with all these challenges, the doctors are doing a great job. They cure, they follow up, they do the procedures, they start when nobody knows from where they can start. And I believe the setup of medical care in this tough situation make the doctors in Egypt very, very talented, very, very special, and they are having a great experience in dealing with any situation wherever and whatsoever. I was told in Sinai, Greece, after graduating from Sinai, Greece Hospital, you will have no surprises out there. Actually, I was not surprised by what he said because already all the surprises I got was from Asra'ini and my training back in Egypt. So additional surprises were just limited for me. The absence of the preventive measures, which I think a major topic that we need to take care of in Egypt regarding the daily pains that we encounter, the problem with the research and development, the medical infrastructure, which is a combination of all of the above, is the future challenges that we need to take care of. Being a good doctor is a process of knowledge processing. It's a clinical skill. It's a diagnosis that we learn to reach with the minimum resources, with a lot of clinical skills. And we know that patients are paying up to the top. That's why in Egypt we follow the tailored investigations. We don't do the stepwise investigations as in the US, where you have to start from the beginning and then you have to escalate it depending on how much you need to do. In here, we trust our clinical skills, our tips of the fingers. We touch the patient, we examine, we get a clear idea about what's going on, and then we order one or two investigations, the minimum that can just prove or approve your theory, rather than starting from the beginning. Knowing all that, doing the minimum investigation, reaching the conclusion, we have the attitude of acute medical management. And I was taught by my professors to do the procedures or to cure the patient as if I would never see him before. We don't know if the patient is going to come for a follow-up or no. We don't know if injecting the varicella feeding next week will happen or no. If I have the patient, then just deal with him right now, rather than just waiting. This is not the situation over there. Over there, I have a patient who can reach me with email, with a phone call, with the clinic appointment, who can be chased by 9 or 10 of the staff in the clinic to respond. And I had to call once a policeman to reach to a patient because I got a critical value of his lab. And it is that serious. It's my responsibility to get this patient to the hospital. In here, if I have the patient in front of me, it's better to just try and treat him right now because I don't know what will happen later on. And the process of being a good doctor with all these challenges leads us to the main theme which we're thinking about, which is the good doctoring. Doctoring is a process. It's not one step. It's not one thing I learned or we teach. It is a process. It's a theme. It's a lifestyle. It's a set of skills, and it's a patient connection to the doctor and the doctor-to-doctor relationship. And it has a lot of humanistic points and entails a lot of the human nature and the connection between patient and doctors, which now they are having a lot of emphasis on in the States and otherwise in other parts of the world. I believe having the tough situations in Egypt with the minimum financial conditions makes a lot of humanistic doctors dealing with the patients on so many ways for free or doing services which might as well would never happen in industrial places like the US, controlled exclusively by insurance companies and very much oriented that the medicine is a business. So how to standardize the medical care aiming to get better outcome and more compliance? your outcome as a doctor will be affected greatly if the patient is not compliant. And you won't be able to do much if you don't know how to get this patient to compliance. It needs the process of doctoring to start even from before getting this student into the medical school. We need to sort out those who are suitable for this job. As the medical educators, we need the teaching, and we need to learn how to teach, and we need to teach the students how to teach later on. Those who have talents, those who have defined capabilities will be put into action, and all of which will be connected together to finally get good doctors graduating from medical school can be trusted on human life. The thinking style of the good doctoring, it has to happen during the medical education with the doctor identity being manifested as is. So one of the ladies who had a nice dictum about it said, her name is Lizzie Gordon, and that was in one of the conferences about the medical education. She said that as educators, we can be seen not only as facilitators of professional identity development, but also as providers of the raw materials that students need to construct their professional identities. So how we can implement this? We do it by shadowing, which we do it automatically in here. But they started in the States to do this as early as in the high school, and they have a college before the medical school, so they need to make sure that whoever gets into the medical career would do it the right way, would really mean to be in this job, and will know exactly what he's getting into. So the students started to shadow the doctors or their mentors as early as in high schools, and it's a de facto requirement for admission to medical school to do so. They have to be exposed to the medical settings, and the undergrads and the pre-medical school years implemented this system. After which they did the shadowing, they started to know if they are suitable for being doctors, and to help the students to contextualize and reflect on their observations after the experience they got. In 2015, they started to add a behavior science section to the MCAT, which is known as Medical College Admission Test, and this is extremely important as it got the interest of a lot of the medical educators with the changes that they implemented after teaching this part. Also, the introduction to the clinical medicine, and this happens very early on. We don't have any more like dead academic few years as a start, and then they start the clinical session. They start early on with the clinical medicine, which has to be applied. No more taking notes on, which is not applicable. No more trying to introduce information to the students' brains which are not used. Even the genetics are clinically applied now. So having the concept of one size fits all is not working anymore. The medical educators tend to use this approach to get a good doctor out there. Everybody here teaches. We are teaching our patients, the families of the patients. We are teaching our nurses, our medical staff. We are teaching the students that we have. But to know what type of student you are teaching is very important, so you would get the good result from your educational experience. So it doesn't fit the complexity of the healthcare system to have a uniform experience. It also doesn't work well with the other healthcare professionals as the way they are working within each other and themselves. And practicing is known to be as an aphorism describing the process of moving from the observation as a student to the mastery of the clinical skill as a graduate. and applying the approach to all the sides of the medical education and experience, including the social and behavioral part. So they started very simple by saying that every student has to see one, do one, and then teach one. So before you graduate your students from the medical school, you need to know that this future doctor will be able to teach others, to teach his patients, to teach his other colleagues and his students. Otherwise, we're not doing it the right way. So the doctoring process will need to be refined if it's not getting the expected results. One of the things that I think we all need to adopt as doctors and clinicians is that we should not wait for the disease to happen and then cure it. It is the concept of preventive medicine. We are consuming so many medications when we don't really have reasons for it. Antibiotics are getting abused. Infectious disease doctors are on the guards thinking that we're running out of antibiotics when we really need them. People who are having the MRSA and resistant infection will have a heavy burden of resistance with the antibiotics now that really very short down the road it will be like really impossible to find something which is effective. And still we still prescribe it. That's how we practice medicine. When I ask people why don't you go to a doctor, I always get the usual answer is because I'm healthy. I feel I'm healthy. Do you know that you're healthy? And the answer would be, I don't feel anything. Well, then you don't know that you're healthy. You might not feel anything and you'll be sick. So you need to go to your doctor and make sure that your doctor says that you are healthy. Get your annual checkup done, get your labs done, know your body mass index, know your hemoglobin A1C. Make sure that what you're doing it right, and you know that you have reasons to say that you're healthy. Keep yourself healthy this way. Go for your annual checkup, and that's something that everybody should really do. We shouldn't just be good doctors, we shouldn't do things right, we shouldn't be just reactive to the problems we get. We need to do the right things. We need the doctoring process to be carried on. We need to do it for ourselves too, to be able to advise people properly. We have to be proactive, and we need the mentors to continue forever. Those who graduate have no mentors, nobody to talk to after they finish their medical schools, will have problems, will need to go to somebody or somewhere to ask for advice. And the mentorship had a whole session in last year's Digestive Disease Week. We got somebody who was giving a lecture about, I am the advisor for my students, but when I need advice, who should I go to? And he said that there had always been in his life a mentor or a professor who would just go and ask him if he needs advice of any kind, medical-wise, social-wise, any of the advices that really crucially needs the well-being of the doctor to be there, to continue. And the preventive measures that we have been talking about, as you know, it's age-related. We have guidelines, European and American. I wish at some point we can see our own guidelines. This society is very special. Our patients are very special. We need our own because we cannot get the others' guidelines and tailor it to our size. We have talked about the annual physical and improving the teaching, and we have really to teach the student how to teach. One of the last slides and the missing parts that I thought I need to focus on, having the experience here and overseas, is these parts which we don't have. We don't have hospitals. Do everybody know how hospice works? So hospice is care for the dying patient. Anybody who is having less than 6 months expectedly in the disease, like the terminal cancers and so forth, they go to hospice. It's a very humanistic part of life to die with dignity, to care about the dying people in the proper way. As doctors, I think it's a big responsibility for us to introduce something like this, since we really need to take care of the patient till the very end. Before the hospice, we have something called palliative care, which take care of the patients if they are not that terminal. It has a lot of dimensions of taking care of pain and controlling pain, as well as taking care of the chronic diseases. Part of these are included and were studied in hepatocellular carcinoma patients and how effective it is if we're having them in such palliative care. Assisted living and SNF are certain other missing areas in Egypt. I think it can be a very good business for those who are seeking for business in medicine. The SNF is the skilled nursing facilities which we can get the patient after liver transplant or after major surgeries to recover in. And the assisted living is the ones which are fashionable nowadays in the US, especially that we are getting in what is known as the silver tsunami. Silver tsunami is the expectation that people will live till 110 years old. And having these people aging that much, then we have as doctors to be prepared to a totally different type of medical challenges that we need to know how to deal with. In the US, by statistics, in 5 years, less than the people who are 85 years old will be more than the kids who are 5 years old. England is an aging continent already, and the US will follow in 10 years. So having the possibility of patients living till 110, I think we should take a lot of care about diverticulosis, cancer colon, cancers in general, geriatric problems, and all these areas need a lot of development. And thank you. Any questions? Thank you so much.
Thank you, Dr. Sahar. Just discussing this point, it touches my heart. Because we get on concentrating on a lot, very advances between endoscopy, treatment of diseases. But actually, what you mentioned